Actually, my talk falls under the complex cases in arthroplasty, which is the retained hardware, and it's all must agree that this is a challenging case scenario for any arthroplasty surgeon. Now, 12% of patients undergoing total knee arthroplasty suffer from secondary osteoarthritis, and presence of hardware in knees undergoing TK cause technical difficulty and increase the risk of post-operative complications. The overall success rate following total knee arthroplasty in post-traumatic arthritis has been reported only 71%, and if there are hardware in Situ, then there are a high rate of complications. Now, Javed Parviz overall evaluated the outcome of the patients with hardware in Situ and compared the rate of complications with the patients without any hardware. And they found out that patients with partial or total retained hardware have a significantly higher incidence of mechanical failure. But the rate of other complications, though it is high, but not statistically significant. Now, what are the problems we encounter with the retained hardware? So generally, the femoral medullary canal is obstructed by the retained implants, and there is a canal sclerosis and obliteration from the callus. Also, sometimes there are extra-articular deformity from the previous fractures. Now, there is a term coined called as a conversion TKR, in which the procedure of periarticular hardware removal is required prior to TKR. And in literature, the conversion TKR is associated with a higher operative time, blood loss, readmission rate, and post-operative complications compared to the primary TKA. There is another paper by Parviz et al. Where he has mentioned the same problems with the hardware removal. Now, other challenges encountered with the conversion TKR are the difficulties with the exposure requiring tibial tubercle osteotomy, sometimes intraoperative disruption of medial collateral ligament and patellar tendons, increased use of stems and augments, and postoperative complications include increased postoperative stiffness and wound complications. Now, there are two ways in which we can do the conversion TKR, either simultaneously with the arthroplasty or it's a stage procedure. Both are having their own set of complications or challenges. If you do the simultaneous arthroplasty and removal of hardware, it may require either 2 incisions or the use of skin flap for adequate exposure, both increasing the risks of soft tissue necrosis and septic contamination. In addition, the screw holes left after hardware removal are potential stress risers which may limit the post-operative weight bearing or require additional support such as stems or struts allograft. If we do a stage approach, then the multiple surgical procedures prior to a knee replacement have been linked to an increased risk of arthrofibrosis and infection. So what are the options available with us if we decide to go with the hardware retentions? The first option is the extramedullary zigs. These are proposed as an alternative on the tibial side. However, femoral extramedullary instrumentation requires a radiographic identification of the center of femoral head with freehand pinning of the cutting block, affecting the accuracy of implant placement. Another option we got is the navigation, and there are multiple papers and case reports available which state that the computer navigation allows the surgeon to obtain good reproducible results similar to routine TKR with a one-stage TKR without hardware removal in post-traumatic knee arthritis. Another case report which states that the computer-assisted navigation system is an beneficial alternative to a standard TKR. This is the paper published by Lin et al. Which state that the results of the study suggest that navigation can help achieve accurate alignment and proper prosthesis positioning for patients with retained femoral implants where the intramedullary rod guidance is impractical. Another option available is patient-specific blocks, and Vaidya et al. Published a paper in Indian Journal of Orthopaedics with a good functional and radiological outcome with the patient-specific block. The literature on the use of robotic technology in such cases is scarce. There is a latest case report published in 2022, January, which state that in a well-planned and selected cases, robot-assisted TK can be a useful treatment for knee osteoarthritis in patients with retained hardware. What are the challenges we can face with robotics? The first one is everyone is discussing is the pin placement. So we do a detailed analysis of the preoperative X-ray of the patient, and we preoperatively decide where we are going to put our pins, and we do some fine adjustment intraoperatively. Now I'm going to show some of the cases which we operated with a Navio system and Cori system in past few years. This is a lady with a mid-shaft femur fracture operated in 2018 with a LCP plate. As you can see, there is a varus deformity at the fracture site, and if we try to remove the implant, there is very high chances that refracture can occur at the previous fracture site. And if we see the screw positions, they are very low. So we went ahead with the CR knee using imageless handle robotic technique. This is another case where the femur interlock nail was present since 2008. And again, we see the tip of the nail is very low. So putting a PS knee was not out of question. So we went ahead with the CR knee, and this is the post-op X-ray. Now another case where the hardware was on the tibial side, and it was there since 10 years, and we can see the lateral compartment is fairly in good condition. So we went ahead with the medial compartmental uni in this case, and we could get away with a good X-ray. Another case where the V-nail was implanted in 1986, and it was an Herculean task to take out such nails which were implanted and there for many years. So when we opened the joint, the lateral compartment cartilage was fairly in good condition. So again, we planned a unicompartmental in this case, and this is the post-op X-ray. Thank you.